Polycystic Ovarian Syndrome, an update. Dr. Eason Sinthaman MD Malaysia, Mercog London, DFFP UK Fellowship in Reproductive Medicine, Singapore UK, Consultant Obstetrician, Gynecologist, and Fertility Specialist Pantai Hospital Kuala Lumpur. Is Polycystic Ovary Syndrome, PCOS, an ancient disorder? Or is it a disorder of recent development, the consequence of rising metabolic stress in an increasingly obese society? And if it is ancient, why has it persisted despite its reproductive disadvantage? From the ancient scripts. But those women whose menstruation is less than 3 days or is meager, are robust, with a healthy complexion and a masculine appearance, yet they are not concerned about bearing children nor do they become pregnant. Diseases of Women 1.6, Hippocrates, 463-77b.c. An ancient disorder? Observations suggest PCOS is an ancient disorder, arising from ancestral gene variants selected and maintained over the past 10,000 years. Such ancient genes likely transmitted transgenerationally through offspring conceived between fertile carrier males and subfertile affected females. The reduced fecundity of affected women potentially would have been offset, at least in part, by their greater sturdiness and improved energy utilization, a rearing advantage for their children and kin, and a reduction in the risk of maternal mortality. Is anything new? PCO versus PCOS. Is metformin useful? Role of ovarian diathermy, drilling. Is weight loss useful? Fertility treatment and OHSS risk. Revised diagnostic criteria for PCOS. 1999 criteria, both 1 and 2. 1. Chronic anovulation. 2. Clinical and/or biochemical signs of hyperandrogenism, and exclusion of other etiologies. Revised 2003 criteria, 2 out of 3. 1. Oligo and or anovulation. 2. Clinical and/or biochemical signs of hyperandrogenism. 3. Polycystic ovaries. And exclusion of other etiologies, congenital adrenal hyperplasias, androgen-secreting tumors, Cushing's syndrome. PCO/IR. Pathophysiology of PCOS. Insulin interferes with follicular development and may affect LH. 2nd. Pathophysiology of PCOS. IGF-1 and 2, important regulators of ovarian follicular maturation and steroidogenesis. Prolonged exp. to androgens causes fall, suppression and stromal hypertrophy. PCO versus PCOS. Up to 23% of normal volunteer women meet the sonographic criteria for polycystic ovaries. Ovarian morphological changes considered a sign and not a disease. Diagnosis of disease based on criteria. However, metabolic similarities including degree of IR, significantly increased risk of OHSS in IVF, insulin resistance. Although not included in diagnostic criteria, IR is regarded as a major, pivotal pathophysiological feature. 40 to 70% of women with PCOS have IR, defined as reduced glucose response to a given amount of insulin. Common in obese and non-obese PCOS. Obese PCOS more IR than non-obese PCOS. Indications that IR and PCOS independent of obesity. Measuring IR. No standard definition and assessment. A unique defect in insulin action and secretion. Possible mechanisms. Peripheral target tissue resistance. Decreased hepatic clearance. Increased pancreatic sensitivity. The pathophysiology of polycystic ovary syndrome. Sealkoroziduti et al. Clinical Endocrinology, 2004 60,1-17. Metformin. Does metformin, or other insulin-sensitizing agents, improve clinical features, hirsutism and acne? Reproductive outcomes, OI, ART. Does metformin help with weight loss? Improves insulin sensitivity. Metformin reduces hepatic glucose production. Stimulates glycolysis in liver. Increases peripheral glucose uptake by the liver, skeletal muscle and adipose tissue. Reduces lipolysis in adipose tissue. Inhibits intestinal glucose absorption. Improves insulin sensitivity. Metformin. Menstrual irregularity, improves menstrual cyclicity in normal weight and overweight PCOS patients. Hirsutism, metformin improves hirsutism in normal weight PCOS patients. In obese patients, long-term, 2 years, therapy may be helpful. Hirsutism and acne in polycystic ovary syndrome. Archer J.S. et al. Best Practice and Research Clinical Obstetrics and Gynecology 18-5-2004. Metformin in ovulation induction. Metformin is beneficial in improving clinical pregnancy rates and ovulation rates. No evidence it improves live birth rates, either alone, in comparison or combination with CC. Insulin sensitizing drugs, metformin, rosiglitazone, pioglitazone, dechironiazole, for women with polycystic ovary syndrome, oligoamenorrhea and subfertility. Tangti et al. Cochrane Databases Trev. 2010 Jan 20, 1, CD 003053. Metformin in ART. In non-obese PCOS patient, BMI less than 28, undergoing IVF/ICSI, metformin treatment, 2000 mg/day, for 12 weeks prior to and during long protocol. Significantly increased pregnancy and LBRs compared to placebo. Use of metformin before and during assisted reproductive technology in non-obese young and fertile women with polycystic ovary syndrome, a prospective, randomized, double-blind, multi-center study. Jatradespi et al. Repred. 2011 May 23. Metformin in ART. In obese patients. Metformin in ART. In women with PCO morphology but no other features of PCOS. Appears to be no benefit of metformin co-treatment before and during IVF in women with PCO without any other features of PCOS. Do women with ovaries of polycystic morphology without any other features of PCOS benefit from short-term metformin co-treatment during IVF? A double-blind, placebo-controlled, randomized trial. Swanton A. et al. Repred. 2011 May 27. Metformin and infertility, summary. For OI. In IVF/ICSI, non-obese patients. In IVF/ICSI, obese patients. In women with PCO appearance only. Metformin and weight loss. Treatment with metformin showed a statistically significant decrease in BMI compared with placebo. Some indication of greater effect with high-dose metformin, greater than 1,500 mg/day, and longer duration of therapy, greater than 8 weeks. A structured lifestyle modification program to achieve weight loss should still be the first-line treatment in obese women with or without PCOS. Adequately powered RCTs are required. Insulin sensitizing drugs for weight loss in women of reproductive age who are overweight or obese, systematic review and meta-analysis. Nieuwenhuis-Ruefrake et al. Reproductate. 2009 Jan-February, 15-1, 57-68. Ovarian drilling number of punctures? Mechanism of action? Laparoscopic versus newer options? Load, first line. When compared to CC as a method of OI in PCOS, load is not superior to CC. Therefore, what is the role if any of load? Randomized controlled trial comparing laparoscopic ovarian diathermy with clomiphene citrate as a first-line method of ovulation induction in women with polycystic ovary syndrome. Amersa. Repred. 2009 Jan. 24 1, 219-25. Load, in CC-resistant patients. When compared to GN4OI, pregnancy rates are comparable. Avoids risk of OHSS and multiple pregnancy. More cost-effective, and better tolerated. Improves ovarian response to CC in at least one-third of CC-resistant patients. Long-term, increases chances of second pregnancy. Side effects, no evidence. Ovarian drilling for surgical treatment of polycystic ovarian syndrome, a comprehensive review. Fernandez H. et al. Repred Biomed Online. 2011 June, 22-6. Long-term outcomes in women with polycystic ovary syndrome initially randomized to receive laparoscopic electrocautery of the ovaries or ovulation induction with gonadotrophins. Nawaz M.J. et al. Repred. 2011 July, 26-7. Obesity in PCOS. 40 to 60% of women with PCOS are overweight or obese. 40 to 70% have insulin resistance. Widespread variability in degree of adiposity by geographical location and ethnicity. Spain, 20%, China, 43%, US, 69%. What is best method to manage obesity in PCOS? In morbidly obese women with PCOS, sustained weight loss and complete resolution of all features defining PCOS, including hirsutism, hyperandrogenism, menstrual irregularity, anovulation, IR and metabolic abnormalities. The higher the weight loss, the greater the benefit achieved. NHI advocates when BMI 35 to 40 kg/m2. Obesity in PCOS. Weight loss. Studies demonstrate fairly uniform improvements in many key features of PCOS with modest weight loss, 5% to 15%. Improvements in biochemical hyperandrogenism, menstrual cyclicity, ovulation, and fasting insulin and glucose as well as glucose tolerance. Obesity in PCOS, exercise. Studies examining the effects of exercise in PCOS suggest that exercise improves reproductive hormones, menstrual cyclicity or ovulation and metabolic features. Remaining research questions: optimal amount, type, duration, and mechanisms of action of exercise. Key features: lifestyle modification is first form of therapy. 500 to 1000 kilocalories/day 7-10% weight loss over 6 to 12 months. Alternative dietary options. Structure and support. Exercise important greater than 30 minutes/day. Letrozole versus CC. Letrozole is as effective as CC for OI in patients with PCOS. Sex steroid synthesis. PCOS and IVF. High risk of OHSS. Strategies to prevent OHSS. Cycle cancellation. Coasting. 4-albumin et al. Antagonist cycles versus agonist, long protocol. GnRH agonist trigger in antagonist cycle. Natural cycle. IVM. Dopamine agonist. GnRH antagonist in agonist cycles, antagonist rescue protocol. Dual trigger antagonist cycles versus agonist cycles. The use of antagonist compared with long GnRH agonist protocols are associated with a large reduction in OHSS, and there was no evidence of a difference in live birth rates. Alinani H.G. et al. Gonadotrophin-releasing hormone antagonists for assisted reproductive technology. Cochrane Database Sys Trev. 2011 May 11 15 C.D. 001750. GnRH agonist trigger in antagonist cycle. In fresh autologous cycles, the moderate and severe OHSS incidence was significantly lower in the GnRH agonists group compared to the HCG group, but was also less effective than HCG in terms of live birth rate and ongoing pregnancy rates. Therefore, not recommended for routine use as final oocyte maturation trigger in fresh cycles except in high-risk women, after counseling. Yusuf M.A. et al. Gonadotropin-releasing hormone agonist versus HCG for oocyte triggering in antagonist-assisted reproductive technology cycles. Cochrane Database SysTrev. 2011, Jan 19, 1. CD 008046, dopamine agonists for prevention of OHSS. Significantly reduces the chances of developing OHSS in IVF and ICSI cycles. No difference in live birth rate, ongoing pregnancy rate, clinical pregnancy rate or miscarriage rate. In T equals 9. Acts by reversing VEGFR2 dependent increased vascular permeability. Can dopamine agonists reduce the incidence and severity of OHSS in IVF, ICSI treatment cycles? A systematic review and meta-analysis. Mohammed A. F. M. Yusuf et al. Human Reproduction Update, Volume 16, Number 5, pages 459 to 466, 2010. Summary: metformin for clinical features, weight loss and fertility. Drilling. Managing obesity in PCOS. Preventing OHSS.